Liddle syndrome, which is an inherited mutation of the genes encoding the subunits of the epithelial sodium channel located in the collecting tubules of the nephrons. This mutation increases sodium resorption and increases potassium and hydrogen ion excretion, hence causing hypertension and hypokalemia. Here we present a case of hypertensive urgency with a high suspicion of Liddle syndrome, who also had a history of multiple pregnancy losses, which has not been described in literature to date. So we have a 39-year-old female with a past medical history of hypertension, multiple TIAs, and 9 spontaneous abortions, who presented with syncope and a systolic blood pressure of over 200 at home. She reported a headache, blurry vision, nausea, vomiting, and abdominal pain for 1 day prior to admission. She was diagnosed with hypertension at age 16. Her blood pressure remained uncontrolled despite multiple antihypertensives. Notably, she was on potassium chloride for multiple years prior to this admission. She also has an extensive family history of multiple paternal family members with hypokalemia, hypertension, and a stroke in her father. On presentation, her blood pressure at U of L was over 200 without signs of end organ damage. Physical exam was otherwise unremarkable. She had a CTA that revealed notorenal stenosis or fibromuscular dysplasia. She did have a low renin and a low aldosterone levels of below normal levels. Her potassium fluctuated from 3.3 to 3.8 during her inpatient stay, despite potassium repletion and potassium-sparing diuretics. High fractional excretion of potassium of 18.55% and high TTKG indicated renal loss. Given her labs and her family history, Liddle syndrome was suspected.
Patients with Liddle syndrome present with resistant hypertension and hypokalemia with low renin and aldosterone. Suspicion for Liddle syndrome in this patient was suspected due to her previously discussed labs and the family history of multiple paternal family members with hypokalemia, hypertension, and stroke in her father. Her history of TIAs is significant because it has been shown in previous literature that hypertension secondary to Liddle syndrome can cause strokes at an early age. Although she has yet to receive genetic testing for Liddle syndrome, it is the most likely diagnosis. In summation, our teaching points include that when identifying patients with adolescent onset hypertension, it is important to utilize a broad differential diagnosis, including Conn syndrome, pheochromocytoma, renal artery stenosis, fibromuscular dysplasia, and genetic abnormalities. In patients with hypertension, hypokalemia, history of TIAs, low renin and aldosterone levels with a family history of similar complaints, consider Liddle syndrome. Despite no known evidence that Liddle syndrome causes or is associated with spontaneous abortions, it is possible that this patient had undiagnosed hypertensive episodes and or undiagnosed, untreated severe hypokalemia during pregnancy that led to her 9 previous